to us a little bit about sort of what a coronavirus is, where it came from, how it became a human disease, and maybe a little bit about how it's transmitted, how it first became a human disease, and then how it's transmitted person to person.
Yeah. So thank you for the introduction. I should, say that I'm, primarily a researcher. I'm a general internist. I have never taken care of a patient with COVID, but I do talk to a lot of people who do, and I read a lot. So everything that you're hearing is, scientifically based and not from my own personal experience. So coronavirus is it's a respiratory virus. It's a family of viruses that causes respiratory infections. It's related to the first SARS virus. If people remember SARS in 2002, 2003, they never really came to the United States. It was, in China, and there was an outbreak in Toronto as well. After SARS, there was another similar virus called MERS, which is Mid-Eastern Respiratory Syndrome. It also didn't come here. So coronaviruses, SARS was much more deadly than our current coronavirus, but they're respiratory viruses, and they're spread in the same way that other respiratory viruses like cold and the flu are spread. So when you ask, sort of like, where did it come from? There are sort of different theories about where it came from. One is likely came from bats. So bats can get this virus and then can transmit it to humans. So it could be somebody who ate a bat, but we don't really know. We don't have sort of a case zero of the first person to get it and to figure out where they got it from. It seemed to, we know that it started, looks like in Wuhan, China, and there was some suspicion around a wet market where they sell kinds of meat that the local people like to eat that we wouldn't generally think of as food, but and that maybe somebody got it from there. There's another theory that it may have escaped from, they also have a virus laboratory in Wuhan. And so it's possible that it was a virus that they were testing and that it somehow escaped from the laboratory. We don't really know where it came from, but it doesn't much matter. It didn't get there on purpose. It certainly got there by accident. Nobody wanted to start this thing. This is not a world plot, but it is very contagious, and it quickly spread around the world.
Okay. So how is it spread, human to human?
Yeah. So, there are sort of three potential ways that it could be spread. So one is through, basically it infects the respiratory tract. So it goes in through the nose, and then it goes into the throat, and then in some people it goes down into the lungs, and that's when it gets to be really problematic. So it causes people often to cough and sneeze, and so that propels virus out into the air. When the virus goes into the air, it can do it in two ways. One is what we call droplets, which are sort of larger particles that you might even be able to see or feel. And those droplets go out, and they tend to fall pretty quickly. So they would fall not far from where you coughed. And that's sort of where the 6-foot rule comes in, that if somebody was coughing or sneezing, that you wouldn't expect the droplets to go more than 6 feet, particularly if they're covering their mouth and or their nose. So of course, if somebody had a really violent sneeze right in front of you, it could go more than 6 feet. And if they were coughing really hard and not covering their mouth, it could go more than 6 feet. So those are droplets, and droplets have lots and lots of viral particles in them. The second way it might be spread is through aerosols. So aerosols are tiny, tiny droplets that float in the air, and they can actually stay there for quite a long time. And so, if you're in a room with somebody, even if you were 6 feet away from them, if they've been in the room for a while, the air in the room could have the droplets in it. Could have the aerosols in it. We don't know whether that's how it's transmitted, but it's certainly possible that it could be. We don't have experiments where we can set up and figure, how people transmit it one to another. And a lot of people who have it don't know where they got it. They had it on their hands and then they touch a surface, or they're coughing into the air and or breathing into the air, could settle down on a surface. Um, on cardboard, less time, probably less than a day. Um, and we don't know how infectious those particles would be. So, if you're wondering, if I get a paper bag with my groceries on in it, and the person touched the paper bag or the plastic bag and they had it on their hands, could it be on the bag or on the groceries? Um, it's possible. We don't know, what amount of virus would be required or how much they would likely have on their hands. Um, Obviously, lots of people going through the supermarkets. I'm not particularly concerned about bringing it home in my groceries, but again, we don't really know exactly all the ways that it can be transmitted. Then the last one is that it does cause diarrhea in some people, and so we think that it could also be um, that it could be spread, what we call the fecal oral route, which is if somebody has, if they don't wash their hands and get their hands totally clean, they can carry around some bits of virus on their hands after they use the bathroom. And so that would be another way that it could be transmitted.
So these masks that have become ubiquitous in supermarkets and wearing gloves in supermarkets, how much do we think those protect the person wearing them and the people around you?
Right. So there are two different kinds of masks, or maybe more than two different kinds, but the two main kinds are the N95 mask, which is what is used in hospitals. And, if you've ever had sort of people come and remove mold from your house, or do stuff where they're making a lot of dust, they're those kind of, they're kind of like blue-green masks, and they're very tight fitting. You actually have to get it fitted to have it work properly. And those strain out pretty much everything that you breathe in. They're supposed to remove 95% of all the particles, which is why they're called N95 masks. Those are probably pretty effective at keeping particles from coming in. Surgical masks and cloth masks like we make don't really protect us that much, but they do protect other people. So if I'm breathing out or I'm coughing out or I'm sneezing out and I've got a mask in front of my face, that actually reduces a lot how much I put into the air. So the idea is that I wear a mask to protect you and you wear a mask to protect me. But people don't generally think that way. We once did a study of doctors and nurses and hand washing. And what we found is that, they're about almost 100% of, cleaning their hands coming out of a patient's room, but only about 70% going into the patient's room. Um, it's not that surprising. We tend to imagine that other people have germs. We don't think that we have germs. Um, and so you might think, well, I'm going to the supermarket. I don't have it. I don't have to worry about spreading it to anybody, and therefore I don't need to wear a mask. But it's a courtesy to the other people and a way to try to protect the community. If we all wear masks when we interact with each other, then we will reduce the spread.
And so there's been a lot of talk about asymptomatic disease or asymptomatic carriers of the virus.
Mm-hmm.
And then on the flip side of that, there are, we hear about young, otherwise healthy people who tend to get severely ill from the virus. Do we have any sense of what causes some hosts or some people to not have any symptoms and some to get severely ill?
Right. So you're asking all of these really hard questions. It's amazing, when you think that there have been millions of people who've been affected by this, and, more than 100,000 people have died, and we still know so little about it. So there is a real range of illness. So there are a lot of, we don't know how many people are asymptomatic. We know you can be asymptomatic and spread the virus. We know you can spread it before you become symptomatic. And then there are people who have sort of mild symptoms. And then there are people who have symptoms and recover and continue to spread the virus afterwards. So there's a lot of people out there who may feel fine that could be spreading the virus. And so again, that's the reason that, we're wearing masks when we interact with each other. And that's one of the things that makes it so difficult without testing to be able to know who's infected and who's not. And so you may have heard, people saying, we need testing, we need testing, we need testing. We're way behind other countries in terms of our ability to test. And so, we just really have no idea. We don't know we don't know how many people have the virus. And we don't know how many people are walking around with it right now. And we don't have the ability to trace the contacts of people who we know have it.
So what do the numbers in Ohio and specifically Cuyahoga County look like as of now? I know, for those of you who don't know, Michael is very active on Twitter, and that's where we get our daily update on the Ohio numbers. But if you could
talk
a little bit about where we are on the curve.
I didn't used to do Twitter. I all of a sudden I would tweet like once a month or something. And then when this started, I thought, wouldn't it be fun to just sort of say every day how many new cases we have? And I thought I was counting down to 0, but that didn't actually happen. So I think we've had about 10,000 confirmed, or maybe we're up to 11 or 12,000 confirmed cases now. And then I'm more sort of aware of how many cases we have every day. Unfortunately, those are just the people who are tested. And there are probably many, many more people who are not tested who have the disease. So it's, we can use the numbers from day to day to get an idea of where we are relative to a few days ago or a few weeks ago, because our testing doesn't change that much day to day. But it doesn't really tell us, how many people still have the disease. The numbers in Cuyahoga County, we're down now to about 20 cases a day, but it's really, it doesn't seem to go below that. So people are still spreading it. There's still plenty of people out there, so it's a good idea to be careful.
Okay. What about treatment options? Can you go into detail a little bit about all the different treatments, the hydroxychloroquine, the remdesivir, plasma, what we know, a little bit how these drugs get approved and how they sort of become FDA approved for treatment?
Yeah. So basically what we know is nothing. We have a bunch of treatments, and again, really amazing that we could have so many people who've been sick and so many people who've died, and yet we know almost nothing. So the few, there are few studies. They're very poorly done. They're very small. When I say small, I mean like 20 patients or 50 patients. They're generally not randomized. So it's just, they gave the drug to a certain number of people and they sort of reported what happened. This is what we think of as kind of like anecdotal evidence or, a case series. It's nothing that the FDA would ever approve a drug based on. Then we have our president tweeted or, told everybody that this combination of drugs was going to be fantastic and was going to be a game changer. And that's clearly not the case. It's not clear if there's any treatment right now that's effective. So there are randomized trials that are going on, and hopefully in a few weeks, we'll have enough patients enrolled in some of these trials to actually be able to answer questions about if anything is effective. Typically it takes a long time to come up with an effective drug for a virus. And unfortunately, when SARS came out, there was interest in developing drugs, and then SARS, kind of fizzled out so quickly that we kind of forgot about it. We could have had 15 years to develop vaccines and drugs and whatnot, but we didn't. So now we're scrambling to do these things as fast as possible. But typically, developing drugs and vaccines takes years. So, we have better technology and we've got everybody concentrating on it, but it's still probably going to take quite some time.
So how far away are we from a vaccine?
So there are two pieces. First, they have to develop a vaccine that's effective. So it begins with isolating the virus. So we've already done that. So that's the first step. The next thing is trying to figure out which proteins or which part of the virus can actually trigger an antibody response. And it has to be an antibody response that's effective in neutralizing the virus. And we don't always know which antibodies are going to work and which ones aren't. So we're sort of at that stage. And then they'll have to test it in humans to make sure that it's safe. And then they'll have to see whether it's effective. And then once we've got a safe and effective vaccine, we've got to manufacture it. And that's going to take a long time. A typical vaccine factory might make 10 million doses, 5 to 10 million doses of a vaccine in a year. So to vaccinate 300 million Americans, you need 30 vaccine factories working full out, doing nothing but making this vaccine. So even if we had a vaccine tomorrow, before we can make enough for everybody who wants it to get it, and that's just in the United States, there's going to be a lot of ramp up that's required.
And so we're talking about antibodies to the virus. So does the data until now suggest that someone who's had the virus already is now immune to it? Or can a person be reinfected after they've already had the disease?
So, typically you cannot be reinfected with the same virus and get sick again. That's true for pretty much every virus. There are viruses that you never get rid of that become sort of chronic infections. So varicella, like chickenpox, is like that. You get the virus, it lives in you. You put it into it becomes dormant. It's lying there, waiting to come back out. And that's what shingles is when the virus reactivates. You're not reinfected with it. You've always got it with you. HIV is another, sort of chronic infection. People get HIV, they develop antibodies, but they're not effective. And so they can never clear the virus naturally. I don't know of any respiratory virus that's a chronic virus. So I think, classically what happens is people clear the virus, they've got antibodies. Then you have things like influenza where you don't get the same strain again, but influenza can mutate. And so next year there'll be a different influenza and you're not protected against that. So it's possible that, if there was more than one kind of coronavirus, that a person might get it again. There are these stories of people who went negative, tested negative and then tested positive. I don't know whether that's a problem with the test or whether they never really were infected the first time or whether they actually never cleared the virus. These are just things that you read in the news. We don't have real scientific studies of this, but there's nothing about the way that this is presenting that makes it seem like it's different from other viruses in that regard. So I would expect that people who are, who've had it and recovered are not going to get it again.
Okay, I think this is going to be my last question, and I'm going to open it up to the audience. But the question of the day sort of seems to be in places, including Cleveland, Ohio, where the number of cases has been relatively low. When do we think it's safe to reopen, and what can we expect when we reopen, particularly given that we think the rate of infection is relatively low and most of the population doesn't have immunity? What can we expect?
Yeah. So all of the so there's so many questions, right? So you said most of the population doesn't have immunity. We don't know how many people have immunity because we haven't done any testing. So there was a study that just came out of Los Angeles where they, sort of tested random people for antibodies, and they determined that somewhere like 30 to 50 times as many people might have been infected as we have, documented cases. It's hard to believe that that's actually true, because if that's the case, then, more than half the people in New York have been infected. Um, and, that seems unlikely. On the other hand, there certainly are going to be many more people who've been infected than we know about. They're the asymptomatic people. They're the people who were symptomatic but never got tested. So we need to be able to test people for antibodies and to do some epidemiologic work. We don't have yet an approved antibody test. There are lots of people who've come up with their own antibody test, but we don't have an approved antibody test. So I should just clarify for people that don't know what I'm talking about. So there are two different ways to test for the virus. What we have now, what most people are doing now, is testing secretions, either nasal secretions or nasal swabs or throat swabs, and then they're looking for the virus itself. Through a technique called PCR, you can cause the virus, you can multiply the RNA of the virus so that you have so much of it that you can detect it. And so even if someone has a tiny bit of virus, you can pick it up. So you're actually testing for the virus itself. A person who had it and no longer has it then would test negative. An antibody test is, once you've been infected, your body makes antibodies to overcome the virus, and those antibodies stay around forever. So you can test somebody to see if they have antibodies. That will tell you whether they had been infected in the past. If you were infected, a couple of days ago and now you're symptomatic, you might not have antibodies yet. So we wouldn't use the antibody test to figure out if somebody's just got a recent infection, but we would use it to tell if people had had it in the past. So once we have an antibody test that's reliable, then we can go and test random people in the population and get an idea of what percentage of them are already.
Okay, so I'm gonna start with some of the audience questions.
Wait, so you asked, like, what's it going to look like when we open back up?
Right,
How will we know, right, when it's time to open back up? So when I say, there's 20 cases a day in Cuyahoga County, those are of the people we're able to test. If you develop symptoms tomorrow, you're not going to get a test. We don't have enough tests. If you come into the hospital and you're in the emergency room, you will get tested. But they're not going to test you unless you're sick enough to be in the emergency room. You can't just go to the emergency room and say, hey, I'd like to get tested. So we're really, hopefully now, I guess Ohio just got permission from the FDA to use some different reagents. But one of the shortages that we had was with reagents that you needed to actually carry out the test. So I heard the governor on Meet the Press last week. He said if we could get those reagents approved, then we could double or triple the number of tests overnight. So presumably we will be increasing the number of tests. So once we get an idea that the number of cases has really dropped and is staying down, then we can start to think about reopening things a little bit at a time, probably for the people who are least at risk when they go out. So we didn't talk about this, but the danger of the virus is different for people at different ages. So it seems like people in their children, people in their 20s and 30s, mostly have mild cases. And I say mostly. Some of those people will die, but it's pretty uncommon to see deaths in that age range. It's the mortality really starts to go up after the age of 50. Of the people who are documented cases, mortality in the 50s is about 1%. And then in the 60s, it keeps going up, and 70s and over 80, it's about 15%. So the older you are, and then the more medical conditions you have, the more dangerous the virus is for you. And lots of people, plenty of young people also have chronic medical conditions. So I think those are people who have chronic diseases, and people who are over the age of 60 are probably not going to want to resume normal activity for quite some time. And even those normal activities, I think, are still going to be with masks and with trying to keep our distance from other people. But they may decide to open up certain stores that are closed now. And they could start to open up restaurants and let people sit, but, every other table or something. So I think it's going to be, it's going to be a long time until things are really back to normal.
So it's going to be a long time till we're back in shul.
Um, well, like, I don't know, could we get a minion of people that are under 60 in our shul? With one person to a row, and I mean, you could sort of like imagine what this could look like. But it's going to be, we're going to have to be really careful, because if we don't have a lot of immunity in the community, and then we get everybody back out and mixing around again, we'll be in bad shape. I mean, we're very lucky in Ohio that the governor was very on top of this. And, he gave the order to close the schools when there were 5 cases documented in the state. That was, really prescient. And if you look at the sort of the curves of Ohio and Michigan, we were about 3 days ahead of Michigan. And you look at what happened in Michigan and you look at what happened here, and I think it's just, it was a gutsy thing to do at the time, and it really paid off. So I think he's going to be very careful about opening things back up. Everybody understands how difficult this is. But I think it would be really crushing if, we went back and then all of a sudden the hospitals were overrun. And I have to say that the hospitals in Ohio have been in extremely good shape. Cleveland, and particularly in Cleveland, but the Cleveland Clinic and UH and Metro have all done a really good job of making sure that they had plenty of capacity, and have surge plans, and, got all kinds of extra beds and ventilators and whatnot, and we haven't needed to use them. So we have, I know at the Cleveland Clinic, there are about 60, 65 patients that definitely have COVID who are in the hospital. And we've been admitting about 50 to 60 new patients each day. So the ins and outs are about the same. People are in for a long time. I think the average length of a hospitalization is about 2 weeks. So if you're sick enough to be in the hospital, it's really awful.
Okay, I think we're going to move on to audience questions.
And if people have questions they want to ask, you can either use the chat feature or please text me if you can't find the chat feature.
Okay. So the first question we got is, if you can smell someone's perfume, doesn't that mean that you are within range of their droplets?
Yeah, I've thought of that. I would say kind of yes. There's also a difference, between when you're indoors and when you're outdoors. So when you're indoors, there's going to be more. The aerosols are going to be floating around, and they're going to stay there in one place for a long time. When you're outside, especially if there's a breeze blowing or whatever, it's going to dissipate very, very quickly. But yeah, I mean, keep your distance.
Okay. Can you explain the plasma treatment?
Yeah, so the idea is, as I said before, that people produce antibodies, and the antibodies appear to be effective, and so the antibodies neutralize the virus. So the idea of the plasma therapy is, if you take plasma from people who have recovered, and plasma is the part of the blood that is not the red cells. That's the part of the blood that has the antibodies in it. So basically what you're doing is you're getting the antibodies that person has made, and that might be an effective treatment. Again, there are studies going on. They have used that for other things, and hopefully we'll know in a few weeks.
Does that work for other diseases? Does plasma treatment work for other viruses, or do we have
yeah, so like if you get bitten by a rabid animal, then you get antibodies that were made by people who are immune to rabies. that's one of the treatments. So it does work for some things. It doesn't work for everything. It may not work for this. Part of what's really interesting or disturbing about this virus is it doesn't seem to be the virus itself that causes the real catastrophe. It's really the person's reaction to the virus. So there's complicated way that the body responds. The immune system's got all these messenger we call cytokines, ways that the cells of the immune system talk to each other. The people that get really sick with this develop what we call cytokine storm, and they end up in the ICU because they've got such an overwhelming immune reaction that they get fluid in their lungs and start to damage their own organs. So we don't know why it does that. There are lots of other infections that cause that kind of reaction, but this seems to do it in a particularly high percentage of people. So we don't know whether for those people, giving them more antibodies may not be helpful. Maybe people who are a little earlier in the course. That's going to be a very, very expensive therapy, and probably not something that we can do really widespread because you got to get people to donate plasma. You can't sort of make it. But as we have more people that have been exposed and recovered, there will be more opportunities. And if anybody here has had it and you've recovered, you may be able to donate plasma for that reason.
How accurate are the tests that we have now?
There are so many different tests. I think there are about 50 different tests on the market right now. So I'm sure that they vary in their accuracy. And so there are going to be false positives and there are going to be false negatives. And I don't think we have any idea about the rate for any particular test. So, if you have a positive test, you're much more likely to have the disease than if you have a negative test. If you have symptoms and you're exposed to someone and then you have a positive test, almost certainly have it. When we think about interpreting test results, usually what we have is what we call your pretest probability. So before you get tested, what was the probability that you had that disease? So if the probability is high, that is somebody who's got the symptoms of the disease and was exposed to someone with the disease, then a positive test is, even if it's not a very good test, is almost certainly going to be correct. On the other hand, if you have no symptoms and you just go test a lot of asymptomatic people, unless your test is really good, most of the positives will be false positives. So it doesn't really answer the question because I don't know the answer to the question, but nobody knows the answer to that question. But if you, part of it is going to be that pretest probability. How likely are you to have it before you get tested? And so we don't have a test that we can then, just sort of massive testing of the population and say if they're positive, they definitely have it. If you had a low probability of having it and you test negative, you probably don't have it. So that would be reassuring.
Okay. Are people at Cleveland Clinic being treated with hydroxychloroquine? What about the 1,000 case series from the doctors in France? And what about the combination of hydroxychloroquine, Z-Pak, and zinc?
Yeah. So some people are using, they were using hydroxychloroquine. We've joined a randomized trial, so we're going to randomize people to get hydroxychloroquine or not. The FDA actually approved the use of hydroxychloroquine only in places where there are no randomized trials. And I would say there was a lot of political pressure for them to approve it. I mean, the FDA doesn't approve stuff like that. They don't approve things unless there's real evidence that they're both safe and effective, and we have no evidence that it's either safe or effective. The study from France has a lot of problems with it. It's not the kind of study that we want to see to believe that something works. And like I said, if we're admitting 50 patients a day to the hospital, we shouldn't have trouble finding enough people. And we're in New York, they're admitting hundreds or thousands of patients a day. There's no shortage of patients. We should not be giving drugs to people hoping that they work and 3 weeks later, we still have no idea whether they do or not. But I can tell you that if this were something where everybody who got treated with it got better, we would have known it a long time ago. Lots of people who get it die. The NIH just came out with treatment guidelines, I think today or yesterday, and they say that you can use hydroxychloroquine. They say there's no evidence for it or against it. They do recommend against using it together with azithromycin because of the risk of heart problems. So there definitely is a side effect when you put those two drugs together. It prolongs we call the QT interval, but it makes you more likely to have an arrhythmia and potentially a fatal arrhythmia. So they recommended against the use of that combination and really outside of clinical trials. So everything is going to be in clinical trials.
When you say there were problems with the French study, what do you mean by that?
So what I mean by it is that it's not a controlled study, and which patients went in and which patients didn't go in and which people were excluded. When we have observational studies, we want them to come out a certain way. And so we tend to cherry pick the information.
Sorry, I'm just going to interrupt you. Explain the difference between an observational and a controlled study for us.
So, so a controlled study is, patients come in and then we flip a coin, and if it comes up heads, we give them the treatment. If it comes up tails, we give them a placebo treatment. And then we look and see which group does better. And we do that because most of the time there's no difference. And sometimes the intervention actually turns out to be worse. And so we're harming people. And so when we're at a point, what we call equipoise, where we don't know whether one treatment is going to be better than another, the best thing to do is to take people and just randomly assign them to get one or the other, since we don't know which one is better. We get into a problem when we start to think that one of them is better, and we start to think that we know so much that one of them is better that we can't test anymore. And so then we just give it to everybody. And then we have nothing to compare it to, and we don't know whether they're actually any better than the other group. An observational study is where we say, okay, well, let's look at people that got this and see what happened to them. But since you don't know what would have happened to them if they didn't get it, then it becomes very difficult to say whether they did better or worse than they would have done otherwise. And we've been misled in many, many studies by observational research, which is what I do. I do mostly observational research. So I'm aware of all the things that can go wrong when you do it and all the ways that it can mislead you. And very often things that looked very promising in observational research, when we did them in randomized trials, they didn't work at all.
The next question, will we ever have kidduses again?
Yes.
Yes, okay, good. Okay, how are CCF, UH, Metro impacted? No outpatient visits and surgeries. At last week, there were a few people and lab was running at 20%.
Yeah, so everybody's under tremendous financial stress. UH announced today that they're going to reduce salaries. I don't know about Metro. Cleveland Clinic has not taken that step yet. Mayo did a few weeks ago. This is very difficult for all the health systems. And they will be looking to restart elective surgeries and whatnot as soon as they feel like they can safely do that, which could be pretty soon.
Okay. Where is Ohio and this county? We talked a little bit about this in terms of the curve. Have we hit the peak yet? Are we on the downslope yet?
So it looked like it really looked like we peaked. I would say about 2 weeks ago, and then we had a little like a sort of a resurgence, but that really just turned out to be the prisons. So I think the cases seem to be coming back down. And I imagine that, in the places like Cuyahoga County, we didn't see a resurgence. It's just been coming down. It's just that the tail is really, really long. So, whereas, we might've been having 100 or 200 cases a day at the peak. And now we're having, 20 cases a day, but we can't seem to get down to 0 cases a day. So we'll just have to see how long it takes for this to really burn itself out.
Okay. Okay. I read a report in yesterday's New York Times about how people are showing up to ERs needing to be put on the ventilator, and their pneumonia has already progressed too far that their lungs they're having difficulty in breathing. Doctors recommended checking oxygen levels using a finger pulse ox, and then if they develop any COVID symptoms, not just those who are having trouble breathing. Do you recommend this? And I assume it can't hurt to be safe.
Yeah, I mean, it's hard for everyone to get a pulse ox. Yeah. So, I mean, we were like looking at different ways of trying to assess over the phone whether you can, how short of breath somebody is. And there was an Israeli study where they have people count and figure out, depending on how high you can count in a breath, that it sort of says, what your oxygenation is likely to be. Unfortunately, it's not like if you get to the hospital sooner, they have all this stuff that they can do. That's the frustrating thing, is we really have no treatments. Everything that we're doing is completely supportive. So it's not like, oh, if you get to the hospital sooner, they're going to give you the hydroxychloroquine and then you're going to be fine. No, you're going to get to the hospital. They're going to monitor your oxygenation. When you start to get short of breath, they're going to give you oxygen. And when the oxygen isn't enough, they'll put you on a ventilator. And then they'll try to support, your other organs so that they don't shut down. But there's not that much that they can do that's actually affecting the course of the virus. They're just waiting for your body to recover from it on its own, and supporting you so that you don't die in the process.
When will results of studies regarding routes of spread, effectiveness of different mitigation strategies, treatments, risk factors, more narrow than age, start rolling in?
So I think the risk factors are pretty, those are pretty well identified. So it's age, it's heart disease, lung disease, high blood pressure and obesity also seem to be risk factors. In terms of the treatments, like I said, I think it'll be several weeks, maybe even a month or two until we've got results from studies. I mean, I think those, as soon as they have a number of patients with results, I think they're going to be trying to get these results out to everybody as quickly as possible. And what was the other question? I forgot.
Routes of spread, effectiveness of different mitigation strategies.
Yeah, the routes of spread is going to be hard. I don't know if we're ever going to know more about what we, than what we know now. And in terms of mitigation strategies, I think we've got experiments going on, around the country and around the world with different countries and different states trying different mitigation strategies. So we'll get an idea, as each of those plays out, which countries and which states are more effective than others.
Okay. If you are in one of the at-risk groups, is it safer to shop in a store using a mask or get groceries delivered through Instacart? My concern is that the delivery people have often not been wearing gloves or masks and would have an incentive to go to work while sick. However, shopping in the store would put me in more risk for aerosol exposure.
Yeah, I think you can, I think that having it delivered is safer than going into the store. We really have no idea how dangerous it is to go into the store. I mean, that's, I would like to do a study. I'm planning to do a study on people who've been diagnosed and compare them to people who haven't been diagnosed and see if we can see a difference in their behaviors. I don't know who the people are who are testing positive every day. And so I don't know what kind of behaviors they've engaged in. If all they did was go to the supermarket wearing a mask and they got it, then I'm nervous. But there are no studies. We just don't know. So I think it's safer to have it delivered to your house. And then if you want, you can use gloves to unpackage it. And then, you can either, if you want to be super safe, you can sort of wipe down the plastic packaging. I think anything that's in cardboard or paper or whatever, within a day is not going to be dangerous for you. So I wouldn't worry about it. And we don't think that, sort of fresh fruits and vegetables are really a problem. The virus degrades pretty quickly on organic surfaces.
And a sort of related question. So you're not worried about bringing the virus home with the groceries for the most part?
I'm not.
Okay.
I think, if it were that easy to catch, then I think everybody would have it. I mean, the estimate is that the factor of spread, we call the R naught, is like 3 to 4. So that each person who's infected infects 3 or 4 other people. If it were that easy to spread that, somebody go and they deliver groceries to 20 people and all 20 of them would catch it, or even 10 of them would catch it, then we would just be having way, way more cases than we do.
That's it for audience questions, unless anyone wants to type one in real quick while Noah closes for us.
So if there aren't any more questions, first of all, thank you so much to Michael for your insight, and your Twitter feed is After Wine with DeWine at 2:00 every day. I really checked your Twitter feed, so I know what it means. And also thank you so much to Chaya for walking us through this, as well as your insight, which you give every night when we watch the news as well. And really, also thank you to everyone who tuned in tonight. It was really good to see so many people. And if you, I'm sure Michael and other medical leaders in our community are always happy to answer questions. So if you don't have Michael's email address, feel free to email me, and we can overwhelm him with questions if things come up later on that you want to ask and forgot. And also, this really has been a time. The VOD put out a statement today, but I just want to sort of reiterate it. We're really praising the community because we are in a difficult, challenging situation, and it's the social distancing measures are not easy, and they challenged us and they made us shuffle our lives around. But the community really has responded really wonderfully to it, and it's a real way when we go about our lives, and every moment we make a choice that we're really literally changing the world. So I would just really thank everyone for everything they're doing, and also there's so many ways to volunteer if you're not in an at-risk category, and if you are in an at-risk category, a lot of people are reaching out to their friends and to their wider community, also checking in on people. That's something we can do from home. So it's wonderful to see everyone, and thank you again to Chaya and Michael, and we will be having another program next week on a different topic that you'll get some more information about in the newsletter.
Thank you.
Thank you, Ray.
Yeah.
Chaya. Thank you, Doctor.